topic is going to be on what to check for breast plants. And we have Sua Yu from Duke University in North Carolina, USA, who's going to be presenting this information. So go ahead, Sua.
Do you see my screen?
Yes.
Okay, you see it. Okay. Hi, this is Sua. We'll start. So today we're going to go through breast and chest wall plan review. And the outline is same as all other series, so I don't need to repeat if we have reviewed already. Patient assessment. First, before simulation, what do we need to know about? Physician's intent. Side is very critical for breast, left to right and bilateral, and whether it's going to be whole breast versus partial breast, and nodal involvement. Those are the things we probably need to know before simulation starts. Prescription dose, if we know in advance, that's great, but sometimes physicians don't tell you what the exact prescription would be. Bolus, typically we have chest wall cases, mastectomy cases, we use bolus, alternative day type of thing. Motion management, whether it's going to be breath hold or free breathing. In general, left side, most of the time we try breath hold in addition to free breathing and compare. Right side, depends. If the liver is well inside of the treatment field, then we might try breath hold as well. And treatment technique, whether it's a 3D, IMRT, VMAT type of thing. But if we don't know in advance, I think as we plan, we can always communicate with physicians and fine tune it. Special consideration for breast, very same as all other cases. Some of implanted hardware would be tissue expander. For breast patient, we see often in America, and whether it's going to be deep breath hold or not. And bolus and skin flash, that's something we need to be aware of. And the scar mark, we need to mark it for the patient, inferior border, superior border, and lateral border, and some of the surgery scar mark. And some patients have drain marks. That's critical type of thing. I'm sorry. Third, other one, prior radiation. Yes, we need to know whether patient had prior radiation or not, whether it was breast, same side, retreatment, or the other side. There will be some possible overlap. We need to know about this, and we need to get all the information. If there's the previous RT-CT, we need to import and register, and overlap might be concerned. And also we need to generate plan sum. Simulation, let's go through simulation. Patient setup, and we go through typical setup. Breast patient, we do supine most of the time, and both arms up and head turned to the other side of the treatment. This is the prone breast board, and treating breast goes into this opening area, and non-treating side gets pulled away. And the head position would be whatever patient comfortable. And some patients, we don't, instead of using the breast board, maybe patient is too heavy or these arms don't fit. So then we might generate alpha cradle or back lock type of thing or wing board. If we put kind of styrofoam wedge so it gets inclined. For the skin fold area, we put bubble wrap, and that kind of put the skin separate. For the breast shape to be more stable and reproducible, we could use breast cup, but then also, I don't know if it's going to be perfectly working or not, because breast cup placement might be different day to day. So it's kind of perfect preference for therapists and physicians, but that's something you can consider. Scar drain site should be all marked with the wires. Image quality, what do we worry about for a breast patient? Metal artifact from tissue expander, or maybe shoulder, if shoulder replacement, metal implant type of thing, we can use OMR. And field of view is critical. Whole entire treating breast should be inside of the CT. What are the variable anatomies? Breast. We're treating breast, and breast is the one variable anatomy. Breast shape could be different. So during planning, we know that it's going to be different day to day, some degree. So that's taken into account. Seroma, tumor bed inflammation, that can change over time. Some patients, this seroma could get bigger, some patients it gets reduced. And drain sites after surgery, patient also gets drained, so it could get smaller. Heart and liver position could be a little bit different. Arm, shoulder, chin, that could vary. So that all we need to consider. Breast patient, we don't do contrast. And implanted device, the same as all other treatment site. Electronic devices, same, not different. We don't need to do anything different for breast patient. We just need to avoid when we set up the beam. Image transfer. Usually for breast patient, we do have breath hold on free breathing CT scan. Then we need to specify, otherwise it gets confused. So the way we handle is we put CT, because it's a CT images, and put the date and indicate whether it's breath hold or free breathing. If some patients, we might do supine and prone both, then we indicate whether it's supine or prone as well. So that's just because we don't want to get confused. And this is our standard. So you need to develop your own standard. Motion management and 4D scan, what do we concern for breast patient? Again, free breathing versus breath hold. And when we check the plan, I always check, is breath hold really breath hold? Is it worth it? 4D images for breast, we don't really acquire 4D images. Most of the time, it's 4D would be lung or abdominal patient. So here's the example of cases. So this case is free breathing versus breath hold. So tumor bed was here, and you can blend back and forth free breathing versus breath hold. When we compare, breath hold is a little bit better. The diaphragm went down, so the liver is a little bit more inferior. Heart-wise, we don't see much difference, maybe a little bit better. Lung expanded some on the right side. We were treating left side, tumor bed was here. When we placed the beam, it was not much different. And plus, this patient did not do so well for the breath hold. So we selected to do free breathing even for the left side treatment. This patient, free breathing versus breath hold was extremely different. Patient did really well, and liver, heart, all got improved. Heart was away from left side and liver was down. So if it was the right side, then yes, we can actually avoid the liver completely, and the lung DVH would be a lot better. And if it's the left side, yes, the heart is away. So we would definitely do breath hold for this patient. So breath hold was selected for this patient. I actually don't remember. Yes, okay. This was the left side patient. I see some of the scar marks on here. So now we have zoom pull. What is not a good reason to do deep inspiration breath hold for breast treatment? First, to spare heart for left side breast treatment. Second, to expand the lungs and reduce lung dose. 3, to reduce treatment time by holding breath. 4, to spare the superior portion of the liver for right side breast treatment.
Okay, so we have a little bit more than half of the participants have already responded. So I'm gonna end the poll.
Yes.
And here are the results.
All right, so yes, correct. To reduce treatment time by holding breath, actually that's the opposite. When we ask patient to hold breath, it actually takes longer because sometimes the threshold is patient doesn't get to the threshold. So it's actually a little bit more difficult than free breathing. But if we do breath hold, heart can be spared for the left side. Lung volume gets expanded, so the lung dose gets reduced. And for the right side, the liver actually pushes down, so the liver can be spared as well.
All right, we have a question, Swat, maybe we can answer now.
Sure, yeah.
And the question is prone position more beneficial than supine?
Yes, for maybe left side, we can actually spare heart and lung better compared to free breathing supine and the free breathing. I mean, prone is always free breathing. Yes, so prone can actually spare a little bit better. And plus the breast actually falls in, so it's actually just like cylindrical phantom shape, and the dose distribution looks actually really good compared to supine. But patient feels a little bit uncomfortable. Like supine would be more comfortable, and prone we see breast only from the side, but when we treat, we want to see where we are treating. So setup wise, it's a little bit more challenging because we set up based on the like back and shoulder. Of course, we do imaging, but we don't actually see the medial side of the breast with the live field. That is the challenging part. And also comfort is another part. That's why maybe we don't do prone for all cases. Later, I think we have some dose distribution I can show you of prone versus supine. Let's
and
go.
another question
Yes.
might be quick is somebody was asking if there's any situation where 4D CT would be indicated.
For breast, we have not done any 4D. 4D would be diaphragm motion or the lung, not really lung, anything inside of the lung or liver, kidney, diaphragm motion. And for breast, 4D doesn't really benefit anything much. And we don't need ITV for breast. And it seems like a chest wall doesn't really move a whole lot during 4D. Should we continue?
Yes, let's continue. Sorry.
Okay, yeah, that's fine. So, okay, now we are going through treatment planning, registration. When do we need to do registration of CT to CT or some other image to CT? Priority, we have priority. Yes, priority planning CT should be registered to new CT. We should focus on sternum position and split the difference for the chest wall, depending on how much arm was stretched and the chin position and inclination of the breastboard, it could be different. Overall, the gap between two medial fields, like previous fields and current field, that would be something we are concerned. So sternum is very critical position. Or if it was not breast, now we're treating breast, we focus on the breast area and relative to the other position. So still we focus on the current position more. Some cases we have diagnostic pre-op PET. Those cases usually have it because we have nodes highlighted. Then we might align the node, we might focus on node area a little bit more. Contouring, ITV, again, breast cases hardly ever do 4D images. And ITV, instead of drawing ITV, we have skin flash. Target and OAR, we have a bunch of targets like breast, tumor bed, chest wall, and all the nodes and scar area is also target. OAR, everybody knows what critical structures for breast: lung, heart, liver, plexus, and esophagus, larynx, and all those stuff. And let's look at the images. This is supine case, tumor bed, and there's clip and scar. We always contour. Tumor bed CTV with certain margin, usually 1 or 1.5, and I think physicians decide what they want, and that's kind of consistent. Physician to physicians or within the institution, we make it consistent. For this specific case, I don't know if you noticed, PTV, yes, we expand from CTV. PTV eval should be exactly same as PTV, except the skin area and the muscle area. But this case is not correct. I think it's probably testing. And breast, yes, we contour whole breast. And when we contour breast, we give 5mm margin from the skin and generate the PTV with the margin, say usually 7mm or 1 cm, depending on physicians. And also, again, physicians, they always make it consistent for their own contours. PTV eval is same as PTV, but we have skin margin, and sometimes physician might shave this pec muscle area and rib position. Prone, same way, and this is correct. Tumor bed, CTV, PTV, and PTV eval has a PTV eval excludes the skin margin area, and breast is the yellow one, and PTV expand out. PTV eval has the skin margin, and PTV eval actually doesn't include all the way to the pec muscle area. And this is the little bit of manual process, and physician manually adjust the contour. Chest wall cases, skin margin is a little bit smaller. We put 3mm, but some cases, if chest wall is really thin, I saw physician not putting any margin for PTV eval. PTV eval goes all the way to the skin. Again, we contour scar and clips. Axillary node, axillary PTV also has margin. IMN node, IMN PTV has margin, but you notice this IMN PTV margin doesn't go to end post direction, and it gets actually done manually. Physician expand it and they shape it off, because if we extend this toward the lung, it's gonna deliver some of the high dose to the lung, and also it gets close to the heart. Supraclavicle area, supraclavicle node is contoured, then PTV gets margin, but toward the medial side, margin is small, and toward the posterior part, the margin is small. It's manually done by physician. This is the reference you can look up, breast atlas from NRG. It shows how to contour all the breast targets and nodes. And there's nodal contouring and margin guideline from MD Anderson. So you can actually screen capture this part and look up the reference. Contour quality, same as all other sites. We would identify missing target, missing slides, or interpolation and stray pixels. Contour margin, again, there's some guidelines, references, and physicians develop their own guideline, and they try to be consistent, but there's a manual adjustment portion each time. External contour and support structure, how do we handle for breast? Question we need to ask is this structure attenuating beam? So let's look at the couch. Tangential beams actually don't go through the couch, so we don't need to contour. But in our institution, we just decide to put couch for all cases except the brain, because just to be consistent. So dosimetries have a habit of just adding couch for all cases. And this couch structure model and density, the HU value, we determined based on measurement. So we actually did a thorough measurement and decided which couch model to use and what number to use. Breastboard, you see the breastboard here, and there's the middle part. Middle part is pretty thick and it's heavy. It would attenuate a lot, but this one, we hardly go through. Beams don't go through unless you treat the spine, and we don't treat spine. Even posterior supraclavicle field don't go through this, so we don't need to include this part. Breastboard here, this part, except the middle, they have a bunch of holes. So it turns out that it doesn't attenuate much, so we don't worry about it. We don't include it. For prone breast, yes, couch should be included, and the table actually attenuate, especially this medial beam. If you see beam's eye view, this portion is included, and it's pretty long distance, and it actually attenuates a lot, so we have to include. And there's the border plate to put the other breast away, and this border plate is very thin. If we put beams directly going through, it attenuates a really small amount, but if it's angled this much, it can attenuate. So we did some measurement and we figured out we can contour it and assign -800 HU. So again, depending on the board, you actually have to do measurement and decide what HU to use and check if beam goes through or not. Density override, only thing we do it is the tissue expander. It's metal and it causes some artifact. Metal itself, we don't need to override the HU. But these artifacts, if you're going to run optimization, it could cause some incorrect fluence. So we contour the artifact, but instead of chasing individual artifact, we just contour whole body, exclude the lung, exclude the metal, and this whole body just put 0 HU. You can put -100 HU because it's mostly fatty tissue, but that would not make so much difference. The different part is these little artifacts. We use OMR, but still this artifact exists. Skin flash, 3D and electron compensator technique. 3D includes a field-in-field technique and static IMRT, BMAT. How do we handle? Let's go through some of the examples. 3D beam, this is the basic classic beam. From tangential point of view, we add the skin flash anteriorly and inferior and some superior, we have enough margin. That is the skin flash. Electron compensator technique, irregular surface compensator, or it's called electronic compensator technique. I call it EComp. EComp technique, we add the fluence manually. And when you generate initial fluence met, it's going to generate fluence only for the breast shape. Then you manually have to add the skin flash all the way to the field edge. That's how you generate the skin flash. about 2 to 3 cm is enough. If you run static IMRT with the tangential beam, if you generate the optimization, what it gives is this fluence just along the target area. So you don't get the skin flash. Then again, very similar to eComp, you have to add the fluence manually to get skin flash. But this is just Eclipse side. It actually only allows you to add so much. It doesn't let you go further beyond a certain distance. So to make this open more, you can actually add a fake flash structure. And when you run optimization, put some of the load constraint, then the jaw opens up and it let you add the fluence at the end. So no matter what, you actually have to add manually skin flash for IMRT. How about VMAT? How do we handle for VMAT skin flash? There are some different references how to handle. So this specific reference, Nicolini, they suggest PTV to extend 1 cm and body to include this fake PTV. So this is actual PTV and expand 1 cm and body should include that. And this layer, instead of air, they put 0 HU value, 0 HU or -100, just like soft tissue. Then run optimization and calculate. When they calculate, they calculate with this external body. What it does is, yes, it is robust because there could be some breathing motion and a little bit of set of uncertainty. Other part is when you run VNet, and if there's no additional buffer for scatter contribution to make the dose high enough for this portion of the target, it just tries to dump a lot of fluence, a lot of MU on it. So you run optimization without any of skin flash, some tissue that provide a scatter. It has a lot of high MU. And if you actually simulate what if this tissue got expanded, what if the target got increased, and if you recalculate, there's really high dose area that's occurring because optimization overcompensates lack of scatter. And then at the same time, yes, this is not going to have enough dose if the tumor grows about 1 cm. So this area gets underdosed, this area gets overdosed. So it generates a robust plan for the breathing motion and edema. And also it generates homogeneous dose over the breast tissue. Another way to do it is this study, Lizondo. Instead of extending body, they actually generate virtual bolus. And virtual bolus, how do they generate? PTV becomes CTV plus 1 cm, then they add the bolus of 1.5 cm. So bolus gets added, and bolus with -500 HU or -100 HU, you just decide. I think either way should be fine. It should not make so much difference. And when you run optimization, link the bolus with the beams. That way, it's gonna have a little bit of scatter contribution from the bolus, so it's not gonna overcompensate the lack of scatter, and it's gonna open the MLC outside of the body, outside of the PTV. And after you're done with optimization, you actually remove the bolus and run those calculations. And because it has low HU value and it is just a half cm more than PTV, the dose difference from optimized dose versus actual calculated dose wouldn't be too much different. And so you don't need to renormalize it. And this generates a robust plan and also homogeneous dose distribution. And from my friend in WashU, I asked what they do. And the way they do it is very similar to the other technique. They actually add 1.5 cm of the bolus, but include some inside of the target, inside of the body, and assign -500 HU and run optimization with this bolus linked. And when they do those calculations, remove the bolus and run those calculations. So what we do here for our clinic is that one. So these techniques, you add the bolus and you actually have to remove the bolus for treatment, for those calculation treatment. A lot of times, chest wall patient, we have to use bolus anyway. And we use a 5 mm bolus. Yes, 5 mm is not so much, but if we use, this is 0 HU because it's actual flat bolus and 5 mm bolus. If you add it for the optimization, it actually opens MLC a little bit. about maybe 3 millimeter or something. It might not, if tumor grows a lot, if edema becomes a lot, it might not be so robust. But at least during for the day-to-day setup and a little bit of uncertainty, this gives enough bolus, enough skin flesh. And as the beams rotate, and there are many segments, so we don't heavily rely on one beamlet. So this turns out that I think it's enough. But for the treatment, if patient is not going to use the bolus, again, we have to remove the bolus and run dose calculation. But bolus should be added before optimization, and then dose calculation without bolus for treatment. And here's a second Zoom poll. What is not a proper way to add the skin flesh for breast chest wall BMAT planning? Number 1, manually open the jaw to add the skin flesh after optimization. Number 2, add a fake bolus about 1 cm, HU value minus 500 HU for optimization. Number 3, expand the external body contour by 1 cm and override HU as 0 HU and run optimization. Number 4, add a bolus of half cm, 0 HU for optimization. And okay, here's the Zoom poll, launch it. So we are selecting something that is not proper. Well, 1/3 done. When it gets about halfway, we can end the poll.
Yeah, we have about 50%, so I'm gonna end the
Okay.
poll at this point.
Yes,
I'm
thank
sharing
you.
the results.
Okay. Yes, I think majority of people were correct. We should not manually open the jaw. So this is for VMAT planning. After optimization is done, you should not touch jaw setting manually, because then it messes up all the segment. Before optimization, so this flesh structure, whether it's bolus or fake tissue, actual bolus, fake tissue, or expanded body contour, that should be added for optimization. And we run those calculations without this fake bolus, then the MLC segments are opened to account this bolus area and skin flesh area. Do we have questions?
Okay, let me close this. Oops. Close the poll. But I think we can. I mean, there are some questions, but let's continue because I think they're more relevant to later sections in your presentation.
Okay. Yes. So we'll continue. Beam setting for breast. Beam setting is very critical. So we'll go through 3D and IMRT. That is like VMAT, not static IMRT. And we have some electron, but in this presentation, I didn't include the beam electron. Beam arrangement we'll go through. So tangential only, very basic thing, supine, tangential only plan. We put isocenter in the middle and medial and lateral. We include the whole breast area with the skin flesh and lung as little as possible, and we should avoid the heart and liver. And we check it in the sagittal view, coronal view, usually about 2 to 3 cm of the lung is included. And always have to double check the beam's eye view. And we have to avoid a collision and beam divergence, we need to check that too. Prone position, same concept, medial tangential, lateral tangential, and we include the whole breast. So as you see it, this supine breast has the long portion included, but when you do prone, the lung is hardly ever included. Even for the right side, it's really skipping off. So that is the benefit of the prone position. And another thing we need to point out is this is our physician, they contour the target PTB valve, but beams don't include it completely. And they don't mind a little portion of not including, like maybe this portion and some of the supine superior portion, inferior portion. I think they contour as a buffer margin. So beams don't necessarily include the entire target. Avoiding the heart lung would be more important. So these are the main simple tangent cases. One thing for prone, we set ISO in the middle of the CT so that it doesn't collide. If you put ISO in the middle of the CT, middle of the breast, this beam might end up colliding on this side. So collision is very critical thing for prone breast. So prone breast, if you sit somewhere in the middle, it might be even outside, but it's going to be clear and we can still plan pretty good for this beam. How about cases with nodes? Partial wide tangent, breast or chest wall with node cases, IMN should be included, supraclavicle should be included. It's a very classic beam. You have tangential beam, but this should open to include the IMN portion. This portion of the chest wall was not included because we had to include all this IMN, and if we expand this, heart gets irradiated. So physician decide not to include it. So it's a physician's judgment. And beam should be matched at the junction, supraclavicle and tangential beam. How do we achieve this straight line? And that's with the couch kick and collimator angle. Supraclavicle beam has a half beam and tangential beam has couch kick. And this, we match it at the skin level. But when you see through coronal view and the sagittal view, the beams are really straight. Cases with separate IMN. So this specific case has IMN included, and if we open up, then we might end up irradiating the heart. Then we can consider separate IMN and make the tangential beam really shallow. And this portion, we can put the electron beam. So electron beam, again, we match at the junction of the supraclavicle medial inferior border. And this tangential beam gets aligned for the coronal view, sagittal view, whole three dimension. Electron beam, ISO is here, so it actually diverges. So it diverges out to superior portion and lateral portion, and because of electron beam ISO distribution, it bulges out. We end up actually having really high dose, about almost 120%, but that's typical for electron IMN. And we still do this old technique, and the physicians are okay about this being super high. But this is a way we can actually have good irradiation for the IMN and still spare the heart. BMAT technique. And there are many different references. I think you can search and develop your own technique after you practice. Things I added are things I like. So it's actually from same group, Bowman and Rosie. The way they suggest is partial arc, but medial type, partial arc, but twice go back and forth, and lateral portion going back and forth. Whether you do this much or that much, I think they say these are very similar. And another technique they're suggesting is maybe don't irradiate in the middle, just open up about 40 degrees, and they try two beams, and then supraclavicle portion. Based on this, actually not based on this, after we had developed some, I found this literature and I found our techniques were very similar. I tried theirs to make it a little bit different, but ours works pretty good for our center. So I think you can try a little bit different way and come up with the best thing for you. So the way we do it is start from medial tangential beam and rotate halfway. And these beams are almost half beam blocked. Halfway, and you overlap a little bit with the lateral tangential arc, go all the way here, lateral tangential, a little further from the lateral tangential beam angle. And then you go back and you go back for medial tangential. And a little bit of like maybe 60 degree, 80 degree for the supraclavicle and IMN node area. We tried this technique, okay, don't have any beam, make it gap. And we tried that, and there is some compensation we had to make it by putting no beams on this angle. You can actually have low dose area, but the target coverage gets compensated. So it's our decision, what are we gonna achieve? I found it's not that one is absolutely better for everything. So we still stick with this beam. I'll show you the beam side view. So
Sorry, so
okay. Yeah.
we have a couple of questions regarding VMAT.
Yes.
One of them is, in regards to the hotspot, is there a specific requirement or is it the same as for 3V plans?
About 110% is what we go by, but for a very big patient, we might even go 112, 113. But 110, we can still achieve. But in general, there are more of 105 volume with the VMAT than 3D.
And another question is, sometimes with VMAT, there's an underdose on the surface. How can you increase the dose in that area?
Bolus. if you put bolus, there's some scatter contribution from bolus. So surface area you can achieve that way. And some of the conflicting area I'll go through where like IMN and heart, that's conflicting area, and also like plexus area. We might have to make it a little bit underdose on purpose.
Thank you, Sua.
Yeah. So we'll take beam's eye view. So in our center, we use 5 or 6 beams. So again, this is the medial tangential. I still call it medial tangential arc. So beam starts from medial beam and goes about this much. It goes about 120 degree. Doesn't need to be exactly 120. It can be 110 or 130. You try it. And initial beam's eye view looks like tangential beam, medial tangential beam. If you open this jaw to include all the way here, you might end up having more of the lung, or you might have to rotate the collimator a little more. You can do it. So this one, start from medial tangential beam's eye view, it rotates halfway. Gantry pulls back about 20 degrees, so there's 20-degree overlap, and now we have lateral tangential arc. Lateral tangential arc, when it ends, this is the final beam's eye view that looks like lateral tangential arc. Using lateral tangential arc, we don't open all the way for supraclavicle for most of the time because posterior supraclavicle is mainly anterior. No point of delivering from the posterior or lateral. So lateral arc, usually we close it. Then this lateral arc had a little bit different collimator. So maybe this one had 550, then this one had 555. And then it's going to rotate back and pull back and end as medial tangential arc. Again, these two beams have slightly different collimator, about 5 degree different or 10 degree different. Again, we didn't open all the way for supraclavicle. Eventually, this gets irradiated from this beam. But number 5, number 6, we add mainly for supraclavicle. And some of the IMN nodes area we focus on. So number 5 beam, open for the supraclavicle, and usually it's about 6 or 80 degree in the anterior portion. Number 6, you can actually do it again, just rotate back for axillary supraclavicle area, or you can make it really narrow to focus on IMN portion. But again, it should be narrow, like 60 degree, 80 degree. If you open more, if it irradiates, then maybe target coverage might be good, but you're gonna ruin the lung and heart dose. And you have to adjust, yes?
I'm sorry. Is there, somebody asked previously if there's a way to treat the nodes in prone position.
I think some centers do it, but we don't do it because we don't see it, right? The nodes, IMN, we cannot verify. Usually IMN node would be along the sternum. We should verify in the light view, but prone, we cannot verify in the light view. If you take cone beam every day, you might be able to align it good. But for prone regular treatment, we don't really take cone beam every day. So, but you can actually still do it. But if you if you have to include the IMN, you might have to include heart and lung more for prone position, but then what's the benefit of prone? So, yeah.
Thank you.
Okay, and so beam deliverability, mainly collision is concerned. Breast patient, we have arms to the side, so we have collision issue. Physicists should remember the number. We have variant length from isocenter to the gantry. It's about 37-ish. There's a little knot for the mount, and that's about a couple of cm if that could touch. So if it's 30 cm, it's not gonna clear. 35 is safe number. And there's some software you can actually check whether it's clear or not. This is from red formation. If you don't have it, go to the most extreme one and put the number ruler and check how many cm that is. Transition, this beam doesn't go through here, so you might be safe. Beam robustness, again, skin flash is the one that takes care of robustness and breast shape changes. So we don't want to highly modulate if breast shape changes. If it's gradual modulation, we'll be safe. Beam energy, most of the time, low energy, but medium and large patient might need some of the high energy, so we can combine 6x and 10x or 6 and 15x. We typically combine 6 and 15 for tangential only cases. If we do VMAT for medium and large patient, we just use 10x beam, but we avoid high energy only plan. Like 15x only, we hardly ever do it because there will be large built-up area. And traditionally, if we use 15x only, we always use bolus, but then we don't really get benefit much. So that's the energy selection. Collimator angle, tangential beams, if you rotate a little bit to go along the test wall, we don't need to irradiate, we don't need to deal with lots of leakage. So that benefits. And when you set up the VMAT plan, VMAT beams, try to go along the tangential, like curvature, long curvature, and rotate the collimator a little bit. And if one beam has this much of collimator, you can do a little bit different for the other one, so you can have more of modulation combination. Superclavicle, always half beam block, and zero collimator and zero couch rotation. And beam's eye view is very critical when we look at when you do plan review breast, always look at beam's eye view. So this is field in field beam's eye view. I would check each segment. So this is beam's eye view. Yes, looks reasonable. And second beam and third beam, it goes through step by step. From field in field, what would you avoid? I would avoid really tiny thin slit. If it's IMRT, yes, we might have each segment really tiny slit, but it's gonna go smooth. But field in field, it's gonna have this as opening for maybe at least 10 MU or something. Why do we not want this? When we do the beam commissioning, we actually have it down to 3 by 3. For a radiosurgery machine, we might have it down to 0.5 by 0.5, but regular machines, 3 by 3. So this is not accurate calculation. So we want to avoid. If any leaf is sticking out or sticking in, if any leaf plays independently, that should be avoided. For breast, generally should go together. It shouldn't be like a zigzag old shape like that. And breast shape, everything should be all smooth. So beam's eye view, you should check this part. Always also look at skin rendering and beam projection. Confirm the matching junction, and if beam goes through the other side of breast or not. This portion, so you can catch it really easily. If that happens, you have to you close MLC or you adjust the angle a little bit, then you can avoid it. And at the machine, therapist also should check the light field so that it doesn't go through the other side of the breast. Shoulder, arm, when we do the beam's eye view here, lots of arm position is in. If you rotate the couch a little bit, actually it gets a little bit better. But even after couch rotation, we cannot completely avoid this, then we might close the MLC. That's how we handle. Other thing, beam divergence, medial tangential, lateral tangential, we want them to meet instead of going opposite, because when it goes divergent, this area gets low dose. Low dose, why do we even deliver low dose? It's not going to treat, and it's just unnecessary dose. We should avoid this part. Superclavicle beam area, this part would be critical. It should avoid a cord. That's the main reason we angle it. But this airway, sure, we need to cover superclavicle, but we need to avoid this throat area. So go through the slides, make sure that this beam line doesn't go to the air side. And from beam's eye view, it's actually pretty tight, but that's verified during the imaging. Third zoom, what is not a concern for making robust plans for breast? Positioning of arms, shoulder, and chin, changes of breast shape, sparing lungs and heart, set of uncertainty.
Do you have the
So
poll?
Yes.
Go ahead and answer.
Did you launch the poll?
Yes.
I didn't. Okay. Yes, I didn't see it.
But for some reason, hold on, let me do it
Yeah.
again. I don't think it did it
Okay.
correctly. It's not letting me do it. Yeah, it's not letting me launch it for some
All
reason.
right. It's okay. I think we can.
It says it has been launched, but it's not showing. So
Yeah, I think people are answering here. Number
yeah,
two.
go ahead and write your answer
Yeah.
in the chat.
Okay. Yeah. I think this maybe is a little bit confusing question. So
Most people are
plan.
choosing number 2 right now.
Yes. So that is the reason we have to consider robust plan, right? But this is asking what's not a concern. So arms and shoulders and chin varies a lot. So here we need to think about what's variables. Arm, shoulder, chin's variable. And when we plan, we need to make sure arms away, shoulder away. If chin is turned, we need to think about robust plan. Breast shape changes, so that's why we need to have smooth transition of the fluence or field in field technique, soft field. We need to think about, we don't want to chase exact breast shape. We want to give some of the skin margin, skin flash. Sparing long and hard is important for no matter what. It's not necessary for robust planning. That's why I put it here. Sparing hard and long, always. For robust planning, yes, heart position could be different. So maybe it's better to have even more of sparing. So maybe I think my question was a little bit concerning, but mainly we want to focus what's variable. Set of uncertainty is also variable. So we need to think about set of uncertainty when we plan. Most of these cases, skin flash and margin, that takes care of it. Dose rate, fastest dose rate should be used to 600, but what about FFF beam? It's a lot faster, but we don't typically use it because FFF beam is not flat, and that actually gives pointed dose distribution, so it is very difficult to make homogeneous dose distribution. You have to run optimization, but then it ends up you might have more of mu values with FFF beams, so it's not used that much. It might be good for partial breast, but you have to go through optimization if you're using FFF beam. Modulation factor, not much of consideration, but breast in general, everything should move smooth. So modulation factor should be low if you have any metrics to look at modulation factor. Beam modifier, wedges, and electronic fluence map, that would be modifier. When we review the plan, always confirm where the wedge direction goes. Wedge should compensate missing tissue. So thick part, thin part, thick part, thin part, makes sense, correct. This is partial breast, and this is the correct wedge direction. For this one, we have to look at sagittal and coronal view. It's angled this way, and missing tissue is compensated, so it is correct. Sometimes I've seen dosimetrists keep putting wedges back and forth and change the beam angle back and forth. I have seen conflicting wedges. Then it's better not to use it. So wedge direction, always check it. Fluence, high intensity for the thicker part, right? And low intensity for the thinner part. So always look at the beam side view. Bolus thickness, here we use a flat bolus, 0 HU. For chest wall, 1 cm bolus could be used, or sometimes we do bolus, no bolus, alternate every other day, or half cm bolus daily, or half cm bolus every other day. It's per physicians, they decide, but per institution, in our institution, we use half cm bolus, half and half. Bolus first all the way to the half, and then no bolus treatment. So bolus, when we plan, we just need to make sure that we actually put the bolus. We don't put bolus all the way to the neck. At the machine, we often use wet towel because it actually conforms better. And for the shallow tumor bed, we would use bolus. In that case, you can use 1 cm or half cm. And if you use bolus, it actually goes all the way to the skin level. This is without bolus, and 100% doesn't cover the tumor bed. So shallow bolus, a shallow tumor area, you need to think about bolus. I mentioned the wet towel. Sometimes wet gauze for the small area, wet towel for the large chest wall area could be used. So flat bolus and wet towel, we actually did some measurement. Standard, this setting is the setting we use for any of attenuation, like couch position and any of tray. We do use exact same setup for all our data. And we actually determined what level, what layer, how many layers to use for the wet towel. Because therapists need to know how much wet towel to use, but also it depends on how much wet that is. Is it going to be dripping? If it drips, then it might damage the machine. So it should not drip, but it should not be completely dry. So there is some uncertainty, some variables, but in rough estimation, 3 millimeter bolus, if we put 2 layers of wet towel, it was actually pretty much equivalent. 1 cm, it needed about 6 layers. So physicists provided this data to therapists. Let's go through optimization. All this is same as all other treatment sites, but for patient-specific cases for breast, what do we look at for optimization? 3D, if we do 3D, what's optimization? We optimize using the beam. Junction should be optimized, so we don't have overlap or we don't have gap. And beam edge should cover IMN and it should cover the heart and the junction. And all this is the optimization for 3D, and we double check this beam setting. Another optimization portion for 3D planning or ecomp field-in-field is balance between target coverage and homogeneity. So this 100% is here and 95% here and not covering completely. And this area not completely covering, but 95% covers pretty good. If we want to improve the coverage, we can actually add the more intensity, but then we're going to have higher dose here. So dose is the homogeneity gets worse. Where do we stop? It would be physician's decision. But once we get familiar with what physician prefer, we know where to stop. So most of the time we would actually make this type of plan because 95% coverage is pretty good and we don't need to have 110% area. But VMAT optimization, what's our optimization constraint stuff? So first, the target include chest wall, supraclavicle, axilla, IMN, and we generate PTV all. And this is all PTV area. PTV has lower objective. This is our typical, these numbers are all relative. If we want to bump up like by a factor of 2, you can, or lower by a factor of 2, that's fine. And you develop your own range of priority. In our institution, for the target for breast, we put about maybe 120 to 150 level or 100 to 120 and put some of the low constraint and upper constraint. And for the body, for the more than like 110% area, you can put very high priority for the upper constraint, then actually limit the maximum hotspot. It worked pretty good. So those are the target constraints. What about OAR? Volume dose, mean dose constraint, what works good for is lung, heart, liver, and larynx. Those work pretty good. For the lung, for the ipsilateral lung, I put about three. If you put like 5, 10, that's too much. You get confused if they're too much. So just maybe 2, 3 works good for the volume constraint. For the total lung, we still put some, and to the other side of the lung, put 2. And priority should be pretty high, about maybe 80, 90. If the target priority is about 120. Heart, mean constraint works pretty good because heart, we want to achieve the mean dose limit, usually about 3 gray, between 3 to 5. That's what we achieve with VMAT. But still, we need to actually limit the volume dose. Larynx, 1 value does pretty good. Larynx volume is small and mean dose works pretty good. And plus, larynx is not too critical compared to heart and lung for the VMAT chest wall cases. Cord, esophagus, brachial plexus, we all have to include something. Cord is very critical, but cord usually doesn't get that much of a high dose. So you can put high priority, but it's maybe you don't necessarily need to. We just don't need to blast unnecessary dose for the cord. Esophagus, maximum dose is critical, and plexus, again, maximum dose is critical. Plexus is very critical, but even 1 for the maximum, if we limit the maximum dose, that's good enough for plexus. Some of the structures we use for VMAT optimization is usually these, we call it Z something, so it all goes to the bottom, so we know what are the structures we use to support those planning. Chin area and arm area. We need to avoid entry. That way, we can, this part, if you think about 3D planning, we just only have this beam. We don't need to go through. So this beam delivers good enough. With the VMAT, beams around here should be good enough to deliver good dose there. So chin and arm, and again, arm side, we don't want to deliver dose from this side. This anterior portion should be good enough. If it goes far to the posterior, maybe we can also put thin arc from posterior angle so that it delivers those here. But we want to avoid the entry through the chin and arm. Ring, what is this ring does? For the medial side of the supraclavicle target, you put a little bit of margin. This is about 5 millimeter or 1 cm, and it goes about 3 cm. And this area, what we want to limit is unnecessary dose. It will get some of the dose because dose has to fall off, but maybe about 50% and 40% dose, we can actually limit. If we think about 3D, we get really sharp dose drop off here. VMAT will be a little bit worse than 3D for this portion, but we don't want to make it too worse. We don't want to give high dose here. So you can actually put some of the constraints so we limit the unnecessary dose. So this Z ring is, that's what used for. For the lung, you don't need to generate another ring for the lung to limit the dose because lung constraint itself can limit the lung dose pretty good for optimization. This is the conflicting objective I talked about. So this is the plexus and this is a target. Plexus is inside of the target. What are we gonna do? We just need to avoid the hot spot. And also maybe we might have a little bit of cold coverage. So this target area, we cover with like 90%, and this 100 might break, but we need to make sure that 105 doesn't appear in the plexus level. IMN is another conflicting object. So IMN, we need to cover it, but it's sitting right above the heart. If we cover this portion all the way, like 100% here, the heart will get higher dose. And also contralateral breast, if we push this 100 all the way here, this dose will spread more. So somewhere we need to compensate. So maybe a little bit of less dose here, less dose here, that is acceptable. So we don't want to push too much for the IMN coverage. We don't want to push too much for the target coverage. We need to allow some of the cold dose area, but still maybe 95 should cover it. Contralateral breast, this, if you don't put any constraint, this actually could spread quite a bit. So put some constraint and decent priority, then this low dose can be reduced. But the goal is to reduce some of the low dose, but we cannot make it completely conformal, like head and neck. It doesn't happen because the dose should go somewhere. So allow a little bit, but not too much. How do you know? You run cases and then you can tell that maybe this is good enough and talk with the physician. If it's spread too much, try to reduce. If it gets too cold for the target, find somewhere midpoint. Normal tissue constraint, usually I put really low priority because we have to allow some of the dose fall off. Dose you should go through and we cannot make it completely conformal. And this dose fall off, we cannot control with this. So we should allow some of the dose gradual fall off. So NTO, I don't use it too much. Dose distribution, all this dose distribution, normalization, how do we do? We use volume normalization most of the time. Volume normalization is not used because of this type of thing. If you use volume normalization, it's gonna bump up the dose a lot and everywhere it'll be too hot. And we have to allow some of the cold area. And also build up area, there could be some of the skin, near the skin, the target might not get 95, but that might be okay. And we don't want to make sure, we don't need to make sure that 95 goes all the way to the skin. And lung and heart interface, we might allow some of the cold area. Algorithm, we use 0.2, 0.3 slide thickness for the CT, and dose grid, we use 0.25 dose grid, which works pretty good. And some of this dose constraint, I think you can screen capture this. These are the references for the dose constraints. Standard fraction, 200 times 25, RTOG gives pretty good dose constraint. Hypofraction, nowadays we do a lot of 267 or 266, 15 fraction, 16 fraction. These references provide a pretty good dose constraint. Fast forward, UK fast forward, 520 or 570, one fraction per day or one fraction per week for 5 weeks. There's some dose constraint. There's UK fast forward. Oh, this is the one fraction per week. And there's also APBI IMRT fluorescent trial, 600 times 5, and there's some dose value. These hypofraction, 500, 600, these dose constraint, it doesn't include the nodes. So mainly limiting high dose. When it goes this high, usually the hotspot, we try to make it lower than 107. So after you actually do this study, you summarize it and you can make Excel worksheet. And this is my own, for my department, breast fast forward and what are the constraints. And it's not going to be absolute, like I put a range 107 to 100 and what are the constraints. Breast and tangential only cases without notes give some guideline for dosimetries and also physicians. Chest wall, breast with nodes, we have a lot of structures. Maybe we don't need that intensive, like stomach, thyroid, cord. Even if it gets violated, we are mostly okay, but we still put the numbers so that we can actually tell whether we can achieve better, whether we can improve better. Heart, lung, plexus are very critical. Left ventricle, LAD are also critical. Coverage, we try to achieve more than 95, but IMN coverage is more forgivable because there's a heart conflicting organ. So these values you can summarize in Excel, or you can have it in the Word document. In record and verifying system, you can upload this so dosimetrists could see it. Categorize per different constraints, and you can give, if it's left side versus right side, give some guideline. And Eclipse treatment planning system has clinical goals, so you can generate clinical goal. One thing we don't want to have too many different goals, then it's confusing. So I divide it in 5 different categories, and whether it's left side or right side. And you see this is the VMAT node case. A lot of constraints are violated. We couldn't achieve, but what are we gonna do? Nothing much we can do. We just know that, okay, we cannot achieve this chord pretty close, then that's good enough. Even if it's violated, if it's good enough, then that's fine. Critical thing would be heart and the lung and plexus. That's something we will always look for. This is another software, Red Formation Clear Check. You can actually generate some of the constraint there, and dosimetrists can quickly check it. And important things on the top, other things, sometimes physicians don't even contour this, like larynx, thyroid, or esophagus gets violated, but you can double check to make sure the hotspot doesn't appear there. And we'll go through some of the isodose vision comparison. So this is 3D, partial wide tangent with superglobal and versus VMAT, how they look different. 3D plan is really good because it doesn't have low dose to other side at all. But what happens is the long dose could be higher, long B 50, which is about 20 gray, could be high. And also junction area, we don't get complete good coverage. And also there's uncertainty each day, how are we gonna handle this junction? So that's uncertainty of the setup. VMAT junction is beautiful. So if this target, high risk target, axillary node is high risk target, then physician just upfront, they decide VMAT. And long V20 could be a little bit better for the VMAT, but VMAT could be worse for the low dose. You see this this is 30% isodose vision. It goes to the contralateral breast, it goes to all the way to the lung, and more area gets this long. You see this long V5 is always worse. And planning text model. Deviated comparison. So VMAT, it's less heart mean dose. Heart dose is actually better for the VMAT, assuming that they achieve similar target coverage. 3D heart D mean could be a lot low if we give up the if we give up the target coverage, but it depends. If we're gonna cover IMN and all this chest wall with the 3D, heart dose can get really high. Long dose V20 for VMAT is usually lower than 3D, but V5 is a lot higher. And that's the same for the contralateral lung as well. And so total lung gets worse for the low dose area. High dose area might be a little bit better. Plexus, we can control better. with VMAT. So that's the benefit of the VMAT. I had this in prono example, high quality versus low quality. Again, VMAT, beam setting is very critical. You practice based on some of the reference, you can practice and develop your own thing. The way we do it is usually 6 arcs or 5 arcs like this. 2 medial tangential and 2 lateral tangential. Don't go back and forth a lot. Medial tangential go and pull back a little bit, and lateral tangential go all the way. Lateral tangential goes back, and then medial tangential, and then a little bit of supraclavicle area. Beam should be mostly half beam blocked, so you don't want to irradiate too much. If you open up more to cover everywhere, long dose, hard dose will be really big, and it is very difficult to control with the optimization algorithm alone. So always check the beam's eye view. It is okay if you don't deliver here because we have supraclavicle beam here. Low quality beam, the way I simulated was full arc all the way from one beam and another arc all the way there. It might be faster delivery, but you cannot achieve good long dose distribution. So initial beam's eye view looks good from medial tangential point of view, but when this beam goes all the way there, if you look at the final beam's eye view, it's not even looking at the target much. Yes, it's looking at the supraclavicle from posterior. Hard dose will be high. Same for the lateral beam. If you go from here to here, initial beam looks okay, but when you go this way, if you do half beam block, you're not even irradiating. Or if you open all the way, and rotate back and forth, it's gonna have a lot of low dose bath, which is not desirable. So dose distribution, what the difference would be if you have low, like a full arc, or if you open up the jaw a lot, you're gonna have a lot of low dose bath, a lot more of low dose bath. Coverage might be better, but our point, we need to reduce the long dose and hard dose. And DVH shows definitely, and long dose, if you do partial arc and if you set the jaw tight, then you can actually reduce some of the long dose. And plexus dose as well. And composite dose, yes, we should always plan some if there's a prior treatment. I brought some examples. So this patient had chest wall plan in 2011, and patient came back for the other side of the breast. And we decided to treat in prone. How do we align? So we still align based on the sternum. That's the basic point. Align based on the sternum. And after you register, you dump the beam, and when you look at it, you look at based on the current CT. Old CT, don't worry about it. As far as you register correctly, you dump the beam and you overlay the dose and check where is the overlap. Overlap occurred, but that was near the tumor bed. So for this specific patient, physicians still decide to treat this full prone breast. Although the physician didn't go all the way to the dip, it actually skimped off a little bit. There was some of the overlap area, but this is what we need to provide as physicists, and we should always double check if dosimetry registered and if dosimetry made a composite plan, make sure that it is reasonable. Some of this communication, I didn't have any specific one. Some of the like setup notes, bolus placement, breathing, breath hold, those notes should be communicated to therapists. And incident learning, if you have any of incident or if you find the dosimetry is doing something not correctly, you share with the breast team and make sure that we all understand we are all on the same page. So we prevent the deviation, and also it's good to be consistent so we don't get confused. So always communicate well with the therapist and dosimetrists and physician.